Good afternoon, everyone. How are you all doing? And thank you for being here today. My name is Tamer Abu Shawarib. I am the Chief Medical Officer for Pacific Edge Diagnostics. We are sponsoring this event today. Again, we truly appreciate all of you coming to our event. And hopefully it will be useful and some good food, but also good information for you about our products. As you may or may not know, we have our product, Cxbladder Triage, has been very recently included in the Microscopic Hematuria Guidelines. And our talk today is going to go through the use of the test and the applications of it. And Dr. Zach Klaassen, who is graciously here to present on our behalf, is going to talk to you about the inclusion and how it got there and the data and so forth. With that, I will introduce Dr. Zach Klaassen to present, and myself and Dr. Jay Javari, who is our Senior Medical Director, will be available to answer any questions afterwards. Zach.
Thank you, Tamer, for the kind introduction, to everybody for joining us for lunch. As we saw in the board meeting yesterday, the sponsorship for this meeting continues to just grow, and we keep having a surplus of money, which is all because of sponsorship. So thank you for, first of all, sponsoring the meeting and for the opportunity to present today. So as Tamer mentioned, we'll be discussing Cxbladder Triage, the risk classification for patients with microhematuria. And there's a lot of stuff coming on the pipeline, so the last half of the talk will be sort of what's coming over the next 6 to 24 months. The first half will be sort of where we are in terms of the data, updates on the AUA guidelines, as Tamer mentioned, as well as some of the historical data that led to this point. So my experience with this is actually very recent, and so I think that the fact that this is in the guidelines really sort of prompted my interest, and so I've started to talk to hematuria patients about this, and the feedback has been unanimously very positive, and so we'll talk about what that data means, what it means for our patients in the shared decision making. This is my disclosures. Nothing relevant. I do some consulting for some bladder cancer companies, and we're starting some clinical trials as well. So we know, this is a group of urologists, we know that asymptomatic microhematuria typically is not associated with bladder cancer. Certainly there is cases of it, but these patients are all over our clinic. We know that about 1/5 of Medicare patients will have hematuria annually. And we know that the majority of bladder cancer, urothelial carcinoma, is going to be secondary to gross hematuria. So if we look at sort of the historical data from a microscopic hematuria perspective, about 3 to 5%, there's been some suggestion that that may be even as low as 1.5% microscopic hematuria leading to urothelial carcinoma. But there's other hosts of reasons for microscopic hematuria. You can see them listed there: kidney cancer, stones, infection, BPH, medical renal disease. So as Tamer alluded to, this is the 2025 AUA SUFU Microhematuria Guideline, literally just published in Journal of Urology February 27th. There's going to be, I'm sure, a huge to-do about it at the AUA in a couple of weeks. So I'm not going to go through this algorithm. It's very similar to the 2020 guidelines. There's some key changes, which we've highlighted on the right, as well as some of the risk stratification, looking at changing some of the ages. The goal of this is to have less patients in the intermediate and high risk and moving more to the low or negligible risk. And one of the main changes was it used to be low risk patients, now it's low or negligible risk. So at this point in time, from the 2025 guidelines, clinicians should obtain a repeat urinalysis within 6 months rather than perform immediate cystoscopy. And that's one of the key changes, is that there is a recommendation for repeating UA in 6 months rather than offering a cystoscopy. And eventually, at that point, this is shared decision making again, but I think this is a key change in the low negligible risk patients. Intermediate risk is where there's a lot of activity. So clinicians should recommend cystoscopy and renal ultrasound. This is the first time we've seen urinary-based biomarkers included in sort of this, what should we do with these patients in intermediate risk? And so at this point in time, you can facilitate a discussion about those biomarkers. You can still do cystoscopy. You should do a renal ultrasound for these intermediate risk patients. With high risk, essentially that's about the same. There's some changes in some of the criteria, just changing the age criteria. But again, these are the patients, the smokers, a history of gross hematuria, older patients, where we should be performing cystoscopy at axial upper tract imaging. So as I mentioned, if you look at the 2020 criteria, there was only 5% of patients that were in the low-risk group. And so the goal of this new sort of algorithm is to put more patients appropriately into low and intermediate risk groups. And so how does it look from our standpoint? Well, there's two ways to look at it. 5% of patients with microscopic hematuria have urothelial carcinoma. You have to do 100 cystoscopies to find those 5 cancers. And this is assuming that 5% of microhematuria has urothelial carcinoma. If it's 1 to 2%, it's even less. Other way of looking at it is if you omit the low-risk patients based on the AUA guidelines, you're still doing 95 cystoscopies to find the same 5 cancers. So there's a lot of heterogeneity in these patients, and so the 2025 guidelines have tried to streamline this a little bit better and better risk stratify patients compared to the guideline 5 years ago. This is an important slide. So what would an ideal genomic biomarker look like? So there's several gaps in terms of difficulty with doing this workup. For instance, a pregnant patient. We all, I assume, practice in the Southeast section. We have patients traveling from 5 hours away to most of our clinics. This patient that's had a workup and there's still microhematuria and you just need a tiebreaker, a biomarker to help you decide if there's something clinically relevant there would be important. And also, to date, until now, the biomarkers we've had haven't been very good. So I think this is another gap where an adequate genomic biomarker would really help these patients. The perfect biomarker, I think, would have all 3 of the things on the right. So it confirms the absence of urothelial carcinoma with a high negative predictive value. Deprioritization of the patients with normal gene expression or low risk. So really taking the patients who you're going to cysto. If you have 10 cysto slots, can we take 2 that we probably don't need to do it on and add 2 that need a cysto? So helping your clinic workflow. And then clarifying atypical or equivocal results from other diagnostic testing. So this sort of sets the landscape for Cxbladder. When we look at the biomarker itself, it's really quite interesting. So 4 of these biomarkers you can see listed there: MDK, HOXA13, CDC2, CDK1, and IGFBP5. These are all sort of tumor biomarkers, proliferation, cell growth, division. But there's also an important 5th one, which looks at high expression if there's inflammation. We all know that inflammation can cause microhematuria as well. And so this is the CXCR2. So this is what the biomarker for Cxbladder is comprised of. This is just a snapshot of the genomic urine test. I'm going to just mention CX Monitor. This specific talk is on hematuria, but this is a variation of this test that we can try to not stop cystoscopies for our surveillance patients, but maybe skip a cystoscopy if they have a favorable Cxbladder Monitor test. And you can see excellent negative predictive value and sensitivity. Looking at the left, which is where we'll focus a majority of the next few slides, this is looking at Cxbladder Triage, low-risk microhematuria, as well as CX Detect. Again, negative predictive values over 97% with excellent sensitivities as well. So Cxbladder has been around for a while, and if we look at the track record of the publications, there's been over 25 peer-reviewed publications looking at hematuria evaluation and non-muscle invasive bladder cancer surveillance, 5 clinical validity publications of over 2,000 patients, 1 independent study of a biomarker pathway versus standard of care in terms of diagnosing urothelial carcinoma. And then really what is driving the guideline recommendation is the first randomized clinical trial, the Strata trial, which we'll talk about, comparing a biomarker pathway to standard of care in diagnosing urothelial cancer in patients with microhematuria. So level 1 evidence, which essentially gave this a level A evidence in the guidelines. And so I commend the patients and the company for doing a true randomized clinical trial, because this is what truly drives changes in practice. So to date, 5,000 urologists, more than 100,000 patients have had Cxbladder at some point in their journey. So in terms of Cxbladder Triage, again, this is designed to identify patients with low probability of having urothelial carcinoma based on both clinical and genomic attributes of this test. And so we've talked about the biomarker gene descriptions. That's in the middle of the screen. But we're also using our clinical characteristics, which we all know is associated with risk of bladder cancer. So your age, your gender, men being more likely to get bladder cancer, smoking history, of course, and then hematuria history. Have they had gross hematuria in the past? So the Cxbladder Triage focuses on this appropriate identification and maybe eliminating more invasive tests for those that may not benefit. This is what the triage score report looks like. And so you can see a score from 0 to 10. The cut point's at 4.0. Less than 4.0 is a negative predictive value of 98.5% of no urothelial carcinoma. Above that cut point of 4.0, you cannot rule out urothelial carcinoma. So you should likely have a discussion with the patient about doing the hematuria workup. It's easy to think about this as a linear test, but it's basically designed as a binary. It's less than or greater than 4. So just keep that in mind when you're looking at your reports. It's a busy slide, but it basically highlights those 5 studies we talked about a couple of slides ago that have really sort of shaped how this test has evolved. A couple of highlights from this slide. It's basically 10 years of literature now. The first study was published in 2015 all the way to the clinical trial in 2024. You can see big studies, a European urology paper looking at urothelial cancer surveillance and hematuria, and really sort of parsing out those atypical cytologies. Huge number of patients in that study. And then again, we'll talk more about the clinical trial, which is at the bottom, which essentially is what led to the guideline changes. And so if you look to the far right of the slide, you see consistency of negative predictive value and sensitivity across all these studies, different countries, different populations, different indications. So this is the first study on that previous table. This is out of New Zealand, and this is really what sort of got the ball rolling. So this is 2 cohorts of patients, 587 with gross hematuria, 40 with microhematuria, with the goal of developing a triage test to guide the workup. And so when we look at the far right, this is the ROC curves. If you just look at the clinical features alone, this is the dotted line, we get an area under the curve of 0.66. If we just take the genes that we talked about, we move all the way up to 0.83. If we combine the genes and the clinical factors, which is the triage score, we get all the way up to an area under the curve of 0.86. So incremental benefit with each of these components. This is the next paper, also out of New Zealand in 2019, looking to further generate data, 571 patients in New Zealand, and basically with the goal of having a clinical pathway for evaluating hematuria with the Cxbladder Triage test. And so in this study, there was 44 urothelial cancers diagnosed. 42 of those were detected by Cxbladder Triage, so a sensitivity of 95.5%, negative predictive value of 98.6%. If you look at cytology, which you use all the time in the clinic, it's basically a coin flip. It detected 22 out of 44 lesions in terms of a 50% sensitivity. So based on the conclusion of this study, 42% of microhematuria and 27% of gross hematuria may have avoided a cystoscopy with a Cxbladder Triage test. All right, I've been talking about this clinical trial. This is a Stratification trial published by Lotan and colleagues last year in the Journal of Urology. The hypothesis here was that in a randomized trial, knowing what the Cxbladder Triage result would be, could this reduce the number of cystoscopies in lower risk hematuria patients? So I'm going to stop here and just sort of explain some of the terminology. The old AUA guidelines divided hematuria into lower risk and not lower risk. And you can see the definitions there, lower risk being 3 to 29 RBCs per high-powered field and a smoking history of less than 10 pack years. Not lower risk being greater than 30 RBCs per high-powered field, greater than 10 pack year smoking history. So all of these patients were given the Cxbladder Triage test. If they were in the lower risk group, they're randomized between the test group provided with Cxbladder Triage versus standard of care control group. If they had a negative Cxbladder test, they could omit the cystoscopy. And if they were not lower risk, they had both the Cxbladder test as well as standard of care. And then the decision and outcomes from the patients were ultimately recorded. The take-home from this trial is that Cxbladder Triage resulted in 59% relative reduction in cystoscopy with an accuracy sensitivity of 90%, negative predictive value of 99%. There was one Cxbladder negative patient that subsequently had a retest and a positive Cxbladder, and this was a patient that actually did have a tumor. So again, this was the trial that subsequently led to these recommendations, which we now see in the AUA guidelines as of the last couple of weeks. So level A evidence, again, Strata showing an overall negative predictive value of 99%, negative predictive value of 100% for high-grade disease, and reducing cystoscopy rates by 59%. So this is just a very simple clinical pathway for Cxbladder Triage. You have your patient with hematuria, you get the test. If the score is less than 4.0, low probability of urothelial carcinoma, you treat them as shared decision-making, can omit the cystoscopy, you can still do the renal ultrasound. If they have a score greater than 4.0, this is standard workup, proceed with the cystoscopy and the renal ultrasound for microhematuria. So this pathway was recently evaluated in the Kaiser Permanente group, presented at the Western section. And sort of their initial evaluation, they had 504 hematuria workups. They got Cxbladder Triage on all of these patients. Negative predictive value of 99.6%. 50% of those patients had a test classified as low risk. only one low-grade TA was misidentified in those 504 patients. 2.7% incidence of bladder cancer, 100% of high-grade T1 and T2 patients were correctly identified by the test. They've gone further now, 1,563 tests, 1,200 had a low probability Cxbladder Triage test, 77%, 23% had a high probability. Of those 363 with a high probability, 85% had cystoscopy. Cancer detection rate was 6.13%. So now, when you look at this real-world evidence, we're up to 77% potentially omitting cystoscopy, so 59% in Strata, 77% in the real world. So don't leave here and say Klaassen's trying to get rid of cystoscopy, because I'm not. We're all urologists. If we're working up BPH and we want a candidacy for UroLift or Resume or whatever, we're still going to do cystoscopy. But it's all about what the value is in patients that are very low risk of having a malignancy. And so I think when I look about this in my practice, again, I've just started using this, the way I look at it is sort of twofold. One is the patient satisfaction. And the patients I've mentioned it to, they're 33-year-old females and they're seeing their nephrologist and they're coming in. We get the renal ultrasound, it's normal. I mentioned this test. They don't know what a cystoscopy is. I explain what it is and they go, let's get the test and let's figure out what we're going to do, because I don't want to have that test. So I'm not eliminating cysto. I'm trying to triage patients and help the clinic workflow a little bit better. We were talking earlier about, if you have 10 cysto patients and you're doing a cysto concurrent clinic with your patients that you see in the regular rooms, if you can free up, your nurses for 2 new patients and eliminate the unnecessary cystoscopy, there's still some benefit there from an RVU or from a reimbursement standpoint. Again, it's all about shared decision making. If a patient comes in and says, I want a cysto, we're going to do a cysto. Doesn't matter whether we get the test or not. So to sort of conclude the first half of this talk, Cxbladder genomic urine test can provide actionable information in hematuria patients. It's made up of the 5 genes, the 4 clinical factors, 4.0 cut point, less than or greater than, NPV of 98%, sensitivity of 95%. As I've mentioned several times, it's now included in the guidelines, and it can be done prior to prior to appointment or scheduling. I have not explored this yet, but I think it's very fascinating, particularly in some of our remote patients, if we can mail them the test and then triage them appropriately from there. So the last 1/3 of the slides are what's sort of coming down the pipeline. And so we have all this great data. The company is already looking at ways to improve that. This is a paper from Lotan in 2023, looking at the 2nd generation. So the aim is to get better than what the Cxbladder Triage test had. And the way they did this is they looked at 389 patients with gross hematuria in the US, as well as 524 in Singapore with gross hematuria. You take the same 5 genes we talked about, but you add 6 SNPs from TERT and FGFR3 into the same algorithm. And so the goal is to improve what we already have. Again, just by way of review, the left is what we talked about. On the right side is these enhanced biomarkers, 6 DNA single nucleotide polymorphisms from both FGFR3 and the TERT mutation. So on the right basically summarizes the results from this paper in Journal of Urology. Sensitivity up to 97% now, specificity up to 90%, 99.7% negative predictive value, positive predictive value up to 44%, and the rule out or the decreased cystoscopy rate of 83%. I like this slide because it kind of sort of compares the two. So we talked about triage in the Strata trial. That's at the top. Detect Plus is what this test is called, is below that, and sort of the incremental improvement that we see with Detect Plus. And so sensitivity up to plus 12% up to 97%, huge improvement in specificity up to 90%, 27% improvement. Hard to improve on 99%, but it went up 0.7% to 99.7%. Huge improvement in positive predictive value, up 28%, as well as the rule-out rate, positive 24%. So conclusions from this study, 2nd-generation tests are being developed with the SNP biomarkers, otherwise known as Cxbladder Detect Plus. It had significant improvement over sensitivity and specificity compared to Cxbladder Triage. Again, 99.7% negative predictive value, only 2 false negative tests in low-grade TA tumors. 83% now could potentially avoid cystoscopy. So it went from 59% to 7% up to 83%. The positive predictive value is interesting. So 16% in triage up to 44%. So 44% of bladder cancer detected with a Cxbladder Detect positive patient in the pooled cohort compared to only 7.7% in intermediate or high risk based on the AUA guidelines. So Detect Plus, just if you're following along, was called that for 3 slides. Now it's called Triage Plus. So we have Triage and we have Triage Plus. So this is the new sort of more expanded clinical pathway based on Triage Plus. So again, we're getting the test on hematuria patients. If it's less than 0.15 low gene expression, manage it as AUA low risk. If it's between 0.15 and 0.54, it's intermediate risk, manage them as AUA intermediate risk. And if it's above 0.54, manage them as high risk. Get your cystoscopy and your upper tract imaging. This is my last slide. So I mentioned at the top, there's a lot of data coming. The test continues to be tested in different scenarios. As you can see on the top left, this was the Lotan study in 2024, the Strata trial. The DRIVE trial will be reporting in Q2 of 2025. The Aussie trial, Q4 of 2025. The MicroDrive trial in Q1 of 2026. And the Credible trial in Q1 or Q2 of 2027. There's already a planned pooled analysis of some of these trials. So I say this because this is not the end of the story. There's a lot of excitement in that last third of the slide deck about even making this test better. And so with that, my take-home message is start to use this in your clinic. We have data to back it up. It's really made a difference in my early experience with talking to patients. Level A evidence in the AUA guidelines. Thank you guys for the opportunity. Thank you for coming. It's been a great turnout for this talk, and I'm happy to take any questions. Yes.
Has anybody looked at this in post-TUR patients? Way to try to replace surveillance cystoscopy to see do they convert to negative after you resect them? And then if they stay negative, do you not have to look again?
So right now, Monitor is just eliminating one cystoscopy. I don't know if you guys have plans to look at that disease space, but I'll let maybe you guys answer that.
Can I? Okay. So as Zach just said, the Cxbladder monitor is intended for that surveillance pathway. However, right now, Cxbladder monitor is only indicated post 9 months of the last TURBT. So we don't yet have that. However, we do have, we're working in the background for that very specific question. We don't have a test yet, but hopefully in the near future we will.
Yes.
Can you explain when to use monitor, detect, and triage? There's 3 different CX tests, right?
Yeah, I had a very similar question. They've got a new sort of one-page order test, and you basically go through, because it's hard to remember which one to use, but it's like, have they had gross hematuria? It's color-coded, takes 3 seconds to fill it out. So basically, that's what I've used in my sort of initial experience. But that order form is revamped, and it's much user-friendly.
Sir, one very easy way to remember is that the Cxbladder monitor test is for your post-TURBT surveillance patients, and then the other 2 tests are the microhematuria area, where it's not going to be relevant if they've had a TURBT because you haven't figured that out yet. So between those 2 tests, one of them has the clinical factors that are associated. The triage test, you have to ask the clinical questions, and the detect test, you do not have to ask those clinical questions, so you could just basically get that test without having the clinical background, and then he went over the area under the curves for all 3.
So detect is kind of a quick and dirty, but the triage is a little bit more, you get a little more, put a little more information in, you get a little more accuracy then.
Excellent,
yes.
Okay.
So yeah, again, to maybe emphasize a little bit on this, detect was the main or the original test, right, where it was just the biomarkers. Triage was intended and is why it was included in the guidelines, is to very specifically focus on the microscopic hematuria patients and increase the negative predictive value. So, because obviously nobody wants to miss tumors, that was the goal of triage, and that's how we increased the negative predictive value. It reduced slightly the negative or the rule out rate. So that's why triage, at least in the initial data, showing a rule out rate of about 50 to 60%, it's now improved to about 70, 75%. Detect has about 70 to 80% from the beginning. So that's kind of the main difference. But right now, triage is the one that has been included in the guidelines, and that's what we did.
Do you know what the questions are that you have to fill out for the triage in a nutshell?
Of course, yes. So triage, there's 4 parameters. There's the gender, age, history of smoking, and history of gross hematuria. So if there is a history of gross hematuria.
So all easy stuff to find in the clinical chart. Bella. I knew you were sitting close to the mic for a reason.
So not really a question, but just, kind of an observation looking at this from the perspective of prostate cancer. I mean, it took us 20 years or longer to figure out that we were over-treating a lot of prostate cancer. I mean, I can remember doing a radical prostatectomy on a Gleason 4 patient. That disease doesn't exist anymore, okay? So, I think that, this is going in that same direction, is to identify the patients where we can kind of de-escalate our treatment. So, I think, maybe we're just 20 years behind prostate cancer with bladder cancer, but headed in the right direction.
Yeah, I think, to your point, and I made this several times, I think, is that you have a huge pool of cystoscopies in your clinic, and it's a huge burden on the clinic staff, your time, and if you take several of those and you move them out, you're going to move people up quicker that need cystos. You can put them, you get new patients in, and the patient satisfaction is huge. Nobody wants it.
Hey, Zach, this is a great talk. Mike Lipkin, I'm from Duke. I have more of an operational question. So when you have these patients and you have the conversation, you rule out the cystoscopy, you get an ultrasound, it's normal. How do you operationalize the repeat UA in a year? I find that's where this whole thing falls apart from a patient flow standpoint, because as a urologist, we're so access starved. You don't want that patient to come back to your clinic to get a UA in a year, but primary cares are busy too and not always able or reliable to do it. So I'm just curious how you guys operationalize that. Think about it.
It's about the same. I mean, we with the negative hematuria workup, we're like perfect. They're PRN, right? If you get gross hematuria, call us back. So I don't have a good answer for that, but I will say, and I should have mentioned in the talk, is because New Zealand's been doing this for a long time, they now have their general practitioners doing the test. If it's a low test, they get the ultrasound. If that's negative, the urologist doesn't even know about them. And then they triage them to go to the urologist if it's a high, or the ultrasound or the CT shows something.
And have you guys looked at, because we also see these patients who, have these 15, 20-year histories of microhematuria, and they may or may not have had a workup at some point, looking in that area where, the guidelines are very vague, right? If it persists, consider repeat workup, and certainly for lower risk patients, we don't cysto them on any regularity. So I'm just curious if there's been anything looking at for those patients, if there's some periodicity where perhaps this test could fill that gap.
I think on one of the gaps, one of the bullet points was if it's those annoying patients. We see them at the VA. We were talking about the VA earlier all the time. They've had a workup 5 years ago, nephrology or PCP sends them back. You're like, do we really need to do this? I think this is a great tiebreaker.
Yeah.
If it's low risk, then you say it's low risk.
Point. Appreciate it.
Yeah, thank you.
Yeah, another point to that, Dr. Lipkin, is regarding benign essential microhematuria, which is consistent in a number of different patients. So all these guys come back for workups. Many of them don't yield anything fruitful, so this could be one way to adjudicate them.
Jed's going to add 5 biomarkers to the test.
No. I'm just interested about, the PCP versus urology space, and what's y'all's plan to, advertise this to primary care docs. They're busy, but they do far more complex things than this. I think this is certainly in their wheelhouse if they're correctly educated.
It gives them more opportunity to give us the PSA of 4 and the 85-year-old, which will be good.
So for this particular question, obviously, it is our intent that eventually, especially with the new Triage Plus test, as Zach has showed you, the data shows even better performance, higher performance in almost every aspect. That is our goal eventually, to go to the PCP. However, it is essential for the urology community to first embrace and really acknowledge the use and take on these tests. Then we can collectively move into the PCP and then stop these patients from coming to the.
Additionally, sir, in other areas of the world, like in New Zealand, where the test was originated, about 70% of their system are already using this test in the hands of primary care because their urology clinics are almost overrun with microhematuria patients. So this is our value proposition within the United States. We mentioned the 77% decrease in the Western section Kaiser Permanente data and the 59% decrease in the Lotan paper. So we intend on seeing this decrease in unnecessary treatment that Dr. Dennis was talking about consistently.
I think we've seen some de-escalation already with low-grade TA bladder cancer. Don't quote me on when they changed it. I think it was probably maybe 2022 or somewhere around there. But that guideline, if there's a 3-month negative cysto after low-grade TA, you can go to that 1 year. So we're starting to see some rational, de-escalation, I guess. Yes.
So I use Cxbladder Detect, or have been using. I'll start using Triage, but the negative predictive value is 97% for that. If somebody comes into your office with microhematuria, the negative predictive value just out of the gate with any workup is 3%. So I'm just curious as to when you would ever use Detect as opposed to Triage to lower that risk.
I think it's reasonable to look at their clinical factors. If you don't have access to their smoking history or their gross hematuria history, sometimes patients are moribund or not non-compassamentous, or they don't have caregivers who have an accurate history. In that situation, the Detect might be the best test to use because it's fast, like you mentioned, without the clinical history. So,
but the risk is still the same. It's still 3%. So why wouldn't you just do a workup from that?
So I think to answer this, it's a little bit more nuanced, I think. If you don't do anything, that patient has a 3% risk, right?
Right.
But all 100 patients have the same exact risk. If you do the test, 70% of those patients will have a lower than the 97%. I mean, you know what I mean? So you're going to focus more on the patients that are positive, which will then increase that probability.
So are you saying that the 3% risk is now cut by 3/4? So 70.
Exactly. So now you're basically increasing the positives that they will have probably 7 to 8% risk of having cancer rather than and the negatives will be a lot less. That's it.
Okay. Thank you, everybody. Appreciate everybody's attention.
thanks so much.